Hello, everyone. Today we're going to go over the anatomy of the pelvis, specifically as it relates to pelvic floor dysfunction. So I have here a pelvic model. This is a female pelvis. I'll point out the differences between the female and the male anatomy as it becomes necessary. We're going to start with the bony pelvis. So you think about the bones as sort of like being the anchor for the ligaments and for the muscles to provide this sort of protection of the organs inside the bony framework, but also a place for those muscles and ligaments to attach in order to create more stability. These large bones here at the top are called the ilia. And if you look from the side view, there's a bony prominence back here, and you can reach back and feel it on yourself. It's called the posterior superior iliac spine, and it's around the area where you might feel a little bit of a dimpling in, or maybe you actually see a dimple in your skin, and you can feel the posterior superior iliac spine there, and that's an important attachment. Right inside the two posterior superior iliac spines is the sacroiliac joint. So this bone here is the sacrum, and it ends in the coccyx. So people talk about their tailbone. Technically, the tailbone is this coccyx bone, and the sacrum is separate from the coccyx bone. Okay? Now, at about age 40, most of the time, our sacrum and our coccyx have fused to form one bone, and there's not a lot of movement of the coccyx. And this becomes important, especially in childbearing with our older moms, because they may not have as much movement of the coccyx out of the way when the baby's moving through the birth canal. If you look back at the side view again, you can see that the posterior superior iliac spine has a counterpart in front called the anterior superior iliac spine. And when we're sitting or standing or motoring through life, you want the PSIS just to be a little bit higher than the ASIS in a normal posture. And this allows our lumbar spine to go into a natural lordosis. And it helps to create more stability through the sacroiliac joint. So that relationship between the posterior superior iliac spine and the anterior is that the posterior is slightly higher. Now, in some readings, you'll see that they need to be balanced, but what you do not want is for the ASIS to be higher than the PSIS, and we'll explain how this affects the pelvic floor and the organs in just a minute. From this sagittal view, if you look at where the pubic symphysis is in the front, it is in the same line with the ASIS. So that's another way of determining the tilt of the pelvis. So turning around to the front, you can see that the ilia turn into this bone here that runs into the midline on each side, and this is your pubic bone. The pubic bone comes together in the midline. It has a cartilaginous disc between the two bones, and the disc allows for a little bit of cushioning. And during pregnancy, this becomes important as well, because there will be a little bit of separation in the pubic symphysis that naturally occurs. It can become a problem if the separation becomes too much. There's no correlation between the amount of separation and if the patient will feel pain or not. The pubic symphysis goes down through the pubic ramus to a bone called the ischial tuberosity. These are down here in the bottom. We like to call them your sits bones because you sit on them, but this is part of the ischium, part of the pelvis. The hip joints are off to the side and front here. So you can see the hips articulate very closely with the other bones of the pelvis. And oftentimes it's difficult to determine if it's a pelvic issue or a hip issue. And so physical therapists have designed special tests to determine the source of someone's impairment. So the bones of the pelvis, as I said earlier, are very important for the ligamentous and muscular attachments to help support the organs. So when we look at the muscles of the pelvis, I'm going to tip the pelvis a little bit more anteriorly so you can see the levator ani muscles. I'll move the pelvis just a little bit closer to the camera as well. So they form this bowl shape. It's a little bit less of a bowl than many of the models make it appear, but somewhat of a bowl shape of muscles that help to support the organs. These muscles have four major functions, one of them being the support, as I said, one of them being that when they contract, they help to close the sphincters, and that's going to be the urinary sphincter and the anal sphincter. And they also help with lumbopelvic stability. So when the pelvic floor muscles contract, it adds to this sort of corset-like action of the transversus abdominis. And so the transversus abdominis is coming together and giving a lot of really nice closure as the pelvic floor is lifting and closing. So together many people call this a bracing maneuver. I think bracing is a really harsh term. And I think that when we use the word bracing, it encourages people to contract really hard. So this doesn't need to be a hard contraction of the pelvic floor. It can be a very gentle contraction of the pelvic floor, and you can feel the transversus abdominis give you that sort of girdle type effect. If you want to try it right now, go ahead and do that. Gently contract your pelvic floor muscles and see if you can feel this sort of tensing of the transversus abdominis. So support, sphincter, so it closes the sphincters. It adds this lumbopelvic stability. And it's also, the pelvic floor muscles are also involved in respiration. So when the respiratory diaphragm, which is way up here, contracts, it moves down and then it comes back up on the exhale. So on the inhale, the diaphragm moves down, and it's very much like a bellows in that the diaphragm moving down, the ribs move out to the side, and then the sternum moves forward just a little bit. So you have this sort of three-dimensional movement of the rib cage and this rising of the belly to allow the diaphragm to move down. Now at the other end, the pelvic floor muscles are down at the base of the pelvis, as you've seen, and as the diaphragm moves down, the pelvic floor muscles are more in this sort of receiving mode of releasing, lengthening. And then as the diaphragm moves back up, the pelvic floor muscles are allowed to move back to their resting position. And the reason for this is many, but one is that as the diaphragm contracts, it's gently pushing down on the abdominal organs and allowing the pelvic floor muscles to, again, receive the pressure, receive the gentle descent of the organs. And then on the exhale, as the diaphragm moves back up, then the organs are going to follow the line of the diaphragm and the pelvic floor muscles can return to their normal state. And this is usually when we encourage a pelvic floor contraction. So there's an inhale, diaphragm moves down, pelvic floor receives. There's an exhale, diaphragm moves up, pelvic floor returns to rest or contracts. So I encourage you to try this on yourself and see how it feels with the inhale and the exhale. So those are the four main roles of the levator ani portion of the pelvic floor. Okay, so let's go over them again. We've got the support of the organs. We've got the sphincter. We've got stability. And then we've got respiration. So you can think of it as like three S's and an R. And those are the main functions. Now, in the female pelvis, if we look at the anatomy from this view, you can see that there are these smaller muscles superficially. And there are three main ones on each side, and these muscles are more involved in sexual arousal, although this muscle here, called the superficial transverse perineal, helps to support that perineal body, which is the area between the vagina and the anus. And so when we have good support of that muscle, then of that tissue, then we have better support of the organs as well. When the perineal body is sort of flattened out, and that happens after childbirth, or if someone who has been straining with constipation most of their life or anything like that, then it can sort of get flattened out. And there's a lack of support there of the entire pelvic floor. And then there's a layer of muscles that's not really shown on this model, and it's between this deep layer and the more superficial layer. And those muscles are embedded somewhat in the fascial tissue, so it's a fibromuscular layer of tissue. And those muscles go around the urethra. And this gets to be really important when we're talking about continence. So those muscles are not as involved in support and in sexual appreciation. They're not as involved in respiration or stability, but they're very important for closing the sphincters. And there's the external urethral sphincter, and then in some texts they'll talk about the compressor urethrae, and in women the urethral vaginal sphincter. So three little muscles that are very, very important when we're talking about continence. So coming into the organs of the pelvis, the bladder is right in the front of the pelvis. Okay. So it's going to be right behind that pubic bone. The urethra in females, it's about 4 to 6 centimeters. In males, it's much longer. And the thing about the bladder that's really, really important is that it is a muscle itself. I'm going to do another video on the physiology of the bladder, but right now just know that this is a muscle and it is able to contract on its own. It doesn't need any help with you to push down or anything like that. It works through the autonomic nervous system. But the muscles of the external urethral sphincter that go around the urethra are striated. And what that means is that you can strengthen them and you can voluntarily contract them. And that's a really, really important thing to know. Now we go back to our posture. You can see that the bladder, hopefully you can see this, the bladder is going to be affected by the posture of the pelvis. And we want the pelvis to be in that little bit of an anterior tilt so that the bladder has really good support from the bones. So you can see that if the pelvis goes into a posterior tilt, instead of having the bony support from these pubic rami here, you've got just some soft tissue, the muscles, giving the support. And so standing or sitting or just working in a position where you flatten out your back all the time really encourages the bladder, you can see this, to kind of fall into the space of the muscles and into that space of the vagina. And that's going to lead potentially to some pelvic organ prolapse. So the other organs in the female pelvis are going to be the vagina and the uterus, which is depicted right here. Okay, and it goes right behind the bladder. Now, this is the usual orientation where the uterus is on top of the bladder. But in some people, they have a tipped uterus or a retroflexed or some other type of retroverted sometimes is used. And that just means that the uterus, instead of being in that over the bladder position, it can be in any other type of position. It might be kind of leaning back into the space of the rectum. And then this is the rectum going down to the anus. You can see that all three of these organs are in this fairly small space here. And that because they are all very mobile, and they're mobile because of the ligaments that support them to the bony pelvis, that there's membranes that are between the organs and allow them all to kind of be like good neighbors and glide and slide on each other and move out of each other's way. So when the bladder is full, then you know, the uterus is lifted up just a little bit, and if you've had an ultrasound during pregnancy or maybe any type of uterine ultrasound, they wanted you to drink a lot of water, and that lifts the uterus up so that they can visualize it a little bit better. So if the rectum is full, sometimes it crowds the bladder. So they all kind of get out of each other's way, and they are able to glide nicely on each other and fill and empty as needed. When we come back to these external ligaments, so I talked a little bit about the ligaments that are supporting the organs, but we also have these skeletal muscle ligaments that are very strong supporters of the joints of the pelvis. This one here, going from the PSIS down to the base of the sacrum, in many texts is called the long dorsal ligament. And then it turns into the sacrotuberous ligament as it comes over to this ischial tuberosity. And you have one on each side. And those sometimes can be, they can be stretched. They have some smooth muscle and skeletal muscle fibers in them, and they can sort of spasm, and they can start to give some dysfunction. They can actually affect the position of the sacrum relative to the pelvis. And so sometimes in physical therapy, we'll do some interventions to relieve some of the tightness in the ligament and to strengthen the muscles that then help the ligament maintain its a good length. And so that's the end of the anatomy lecture. I hope you found that helpful. I encourage you to read more on the subject if you're interested. And I'll tune in for the physiology lecture that I'll be doing shortly. Thank you.